Welcome to this Buxton Mountain Rescue Team demonstration of a primary survey in a trauma patient. It is a guide of the primary survey, the approximate time that it should take, and how and when to treat life-threatening illnesses. This film will reassure BMRT rescuers that by following our ABCDEF primary survey procedure calmly and systematically, they will identify injuries which need treatment and will also avoid the red mist which affects everyone, irrespective of experience, when faced with an injured person. Danger. The primary survey starts even before the rescuers are at the side of the casualty. The rescuers must remain calm on approach and consider the possibilities of injuries to themselves, and also make a reassuring first impression of the casualty. In this scenario, the patient could be suffering from multiple potentially severe trauma conditions, and so the first aider must be thorough in their approach to the primary survey. The primary survey starts on the approach to the casualty. Someone screaming in pain is very distressing, but obviously they have a clear airway and are not unconscious. A quiet casualty, particularly in this scenario, may suggest a big sick patient. The first concern of the rescuers is their own personal safety. It is too easy to rush in to treat a casualty and miss dangers to themselves, the casualty, or other members of the team or public. As soon as you arrive at the scene, remember danger, and think not only of the casualty, but of the environment and the bigger picture. Imagine yourself looking at the situation you're in quickly from many different angles before making a judgment.
We should put our helmets on here.
Here, the casualty is at the bottom of the cliff face, and so may well be exposed to falling objects or other dangers from above. As a result, the rescuers must take as many steps as possible to protect themselves from harm. Having two casualties is of no benefit to anyone.
We've got a casualty here, Jeff. Gloves on.
The casualty carer must protect themselves from infection. All casualty carers should put on gloves, but depending on the individual scenario, it may be necessary to identify the need for protective glasses or other protection.
Control, this is Buxton 1, over.
Control, send, over.
Yeah, Control, request call sign change to
Charlie 1, over.
Next, our first aider tries to elicit a response from the casualty. A friendly and reassuring welcome and introduction from our team member explaining their role will always go a long way to helping to calm the casualty's nerves at this stage. Now, if we were to consider a situation where our casualty was not able to talk to our rescuers, this may imply something more serious is occurring. Our rescuers may wish at this stage to call for additional support, consider early medical assistance and a rapid evacuation. An unconscious casualty should be managed following the basic life support algorithm, starting with the assessment of the airway. Airway and C-spine protection. The first and often most frightening part of the primary survey is the assessment of the airway and protection of the C-spine. Our first aider must decide whether the mechanism of injury sustained by our casualty potentially places the casualty's neck at risk. The first aider's assistant has immediately placed two hands either side of the casualty's neck to prevent movement and provide some protection. First decide whether the casualty has a clear airway, which allows air to move from the outside into the lungs. For completeness, our rescuer has looked inside the casualty's mouth to ensure that no foreign materials are present, excluding blood, vomit, or teeth, or anything else potentially obstructing the airway. He has then placed his cheek next to the casualty's mouth and his hand on her chest, therefore looking, listening and feeling for air movement, and indeed a simultaneous assessment for the presence of breathing. In this situation, it is easy to feel breath on the rescuer's cheek and see the chest rising and falling. Our rescuer is also reassured by the lack of additional sounds, suggesting potential or partial airway obstruction. Sounds such as stridor, gargling, snoring, or more worryingly the total absence of sound at all, may be concerning. Our first aider has made a decision and decided that, based on the situation and lack of obvious signs of immediate problems in breathing and circulation, that providing further support to the C-spine is appropriate If there are concerns by our first aider at this stage that the immediate problem may be present in breathing or circulation, and by putting a collar on now, vital life-saving treatment may be delayed, then he may elect to not fit the collar now, instead just leaving the assistant to support it as best possible, fitting the hard collar at a later time. Once our first aider is satisfied that the casualty's airway is clear and that the C-spine has been protected as much as possible, he moves on to an assessment of breathing. Breathing. In this scenario, although we are satisfied that the airway is clear and that the neck is relatively protected, this does not guarantee the absence of a problem with breathing. Here our casualty is breathing by herself, and so we do not need to start breathing for her with a bag valve mask. The first aider must assess the adequacy of the casualty's breathing. Does it look strained, difficult, or laboured? What is the depth of breathing? Is it shallow? Is it deep? Or is it normal? A normal breathing rate is 12 to 15 breaths per minute. Getting down to skin level and placing 2 hands on either side of the casualty allows for an accurate breathing rate to be calculated, and will allow the rescuer to assess for the symmetry of breathing, as well as looking for injuries and feeling the chest wall to exclude fractures or wounds that would be otherwise missed. Our protocol in Buxton Mountain Rescue Team is to give supplemental oxygen to all casualties, whether big sick or little sick, a non-rebreathing mask with a flow rate of 15 litres per minute. After inflating the bag, the mask is placed onto the mouth and nose of our casualty. Our rescuer has also placed a pulse oximeter onto the finger of our casualty, enabling 2 vital pieces of information to be obtained. Firstly, it gives a figure as a percentage of how much oxygen is in the patient's blood. A healthy person, or even someone having suffered major trauma, should have oxygen saturations of equal to or greater than 96%, and the oxygen being administered can be dropped to tailor to this number. Secondly, the pulse oximeter also provides a pulse rate. Other injuries that may require treatment in the breathing section may include a hemothorax, a sucking chest wound, or a flail segment. Circulation. Circulation assessment is a vital skill for any first aider. Subtle changes in the key indicators may well give advanced warning that a casualty's condition is deteriorating. An initial assessment of circulation status is achievable even before touching the patient. A quick look at the colour of the patient, in particular looking for whether the patient is pale or not, may help raise suspicions of a lack of blood early on. The other 4 areas, the chest, the abdomen, the pelvis and the femurs, are vital places to look at, as large pools of blood in these areas should be checked quickly during the circulation assessment. A more focused circulation assessment can now be carried out. Firstly, our first aider feels for the casualty's pulse at the wrist, looking for the radial artery. Here he is assessing the rate, but also importantly the strength of the pulse. A normal pulse rate at rest is between 60 to 80 beats per minute. Having taken a radial pulse, the first aider checks capillary refill time. This should be less than or equal to 2 seconds, and in our casualty, in this scenario, it is. This combined with a good heart rate of 80 should reassure our carer that the circulation in this casualty is currently okay. Finally, our carer makes sure that the checks the 4 key areas where bleeding could occur. Having already checked the chest in the breathing section, he makes a quick feel and look at the abdomen to exclude injury, bruising or pain, before checking the pelvis and the femurs. Disability. The disability section of the primary survey is a vital step to try and tease out the often subtle signs of serious injury, especially in a trauma scenario where the head injury or spinal cord damage are a real possibility. Our first aider has covered the casualty with a box tent and makes every effort to keep her warm. Our first aider should be relatively relieved by the fact that our casualty is alert and orientated and not confused or agitated. She therefore corresponds to an A on the AVPOO scale. Our first aider asks the casualty to wiggle her toes and fingers. This normal movement, normal appropriate words, and spontaneous eye-opening means our patient also scores 15, the maximum score on a Glasgow coma scale. As well as confirming movement, the casualty is asked about abnormal sensation in any of her limbs, including numbness, weakness, or pins and needles. Reassuringly, especially considering the mechanism of injury, she is not experiencing any abnormality. Our first aider next looks for evidence of head injury. No obvious bruising or wounds are seen to the head, and by looking in her eyes he can confirm that both of her pupils are equal in size and both react to light with the use of a pen light. As our casualty is conscious, she is also asked to rate her pain levels, and as she says she has no pain, no analgesia is required, but options may include Entonox, paracetamol, non-steroidal anti-inflammatory drugs, morphine or fentanyl lozenges, as deemed appropriately. Exposure and fractures. It is very easy, with the glare of red mist and all the medical management that is going on, to forget that our casualty is at the bottom of a cliff edge and exposed to the elements. We must make sure that the casualty is protected from wind and rain, and ensure that if signs of hypothermia are present, then they must be treated effectively and promptly. Our first aider has identified that the mechanism of injury, i.e. a fall from height, for this casualty may have resulted in a pelvic injury, and so he has applied a pelvic splint to prevent deterioration in case there is one. Treatment in this section of the assessment may include laying the casualty down and elevating the legs, splinting a suspected femur fracture, controlling hemorrhage with direct pressure, indirect pressure, or dressings. Based on the situation and lack of obvious signs of immediate problems in breathing and circulation, that providing further support to the C-spine is appropriate at this stage. The neck collar provides some protection against neck flexion and neck extension, but without blocks and tape or a vacuum mattress support, a neck collar does not prevent all movement. Importantly, the assistant must stay holding the casualty's head to prevent additional movement not prevented by the neck collar. Now that our casualty is in a controlled environment and free from injury that is likely to be life-threatening or limb-threatening, our first aider can take some time to double-check our casualty for any other indicators of injury. Now our first aider checks for injuries that may have been missed during the initial assessment. In this process, he deliberately assesses all the major long bones of the body in an attempt to exclude injury. Any injury discovered here should be treated in the most appropriate manner with dressings, splintage, and/or analgesia. With life and limb-threatening injuries excluded, the casualty warm and protected with minimal or no pain scores, our first aider can now set about taking an ample history while waiting for further support to arrive and handing over to control or ambulance crews. You should now hopefully feel much more confident about how to carry out a primary survey. The common mistakes happen when people get distracted by obvious injuries but missing the silent, more life-threatening ones. Try to be logical in a more sensible manner and carry out your assessment in a ABCDEF approach.